Hey everybody, welcome back. It's Kathy Randall from Synapse Care Solutions, and we are ready to have another Monday live stream with you. Today's presentation addressed the issues of delivery room cuddles. This is a practice that has been going on in the UK for over 20 years, but it has recently had a lot of attention, some new publications, and we were so lucky to have Dr. Paul Clarke, Dr. Paul Cowley, as well as a family who has experienced delivery room cuddles talking to us about the impact that it had and just the benefits. This was one of the most popular presentations we had during the pandemic. It was on one of our Synapse community calls, and I'm so excited to be able to bring it back to you. If you'd like to have some of the resources that are mentioned, as well as the slides, go ahead and scan the QR code here, or check out the show notes below for more links on this and other Synapse Care programs. So without further ado, please enjoy this presentation. Thanks again, and I will see you at the end. I don't want to hold up this presentation or to hold up the time that you have with these clinicians and families who are here to share this experience and this amazing effort. And Dr. Paul Clarke is here with us. He's going to be presenting this, as well as Dr. Paul Cowley. They're both from the UK, and here to tell us about all their amazing work that they've been doing on delivery room cuddles. I met Paul over dinner in Munich, I think, 5 or 6 years ago, and he had just published his first paper, I think, on this topic, and we got to talking, and I thought it was just amazing, the work that he was doing, and I loved this word that he has created around this experience for families about delivery room cuddles. He is a consultant neonatologist, as you see, and he has a passion for helping families to create those first emotional connections and moments in the delivery room. He is going to share with us his research, his practices, some videos, and you are in for a treat. So I'm happy you are all here. And with that, I will let you take it away, Paul.
Thank you, Kathy. Good morning, good evening, good night, wherever you're dialing in from. It's a real pleasure to be able to present to you today. So thank you, first of all, for Kathy, for the kind introduction and for the invite to speak today. I'm honoured to have with me two out of the 3 co-authors of the paper we recently published related to this, which I'll give you the link for at the end. So Dr. Cawley is present as well and will be willing to answer any questions with me at the end, as will Sheila. So Sheila, we're honoured to have her. She's a mother of an extremely preterm, extremely special little lad, and she can tell you directly her experiences for anyone who wants to ask parents' views. To get through, I'm going to talk about a very simple concept, which is being able to facilitate the baby being cuddled by its parents in the delivery room before neonatal unit admission. So I'll start by showing a little video. I hope this comes through.
I'm Amy, and this is Lily Rose. She was born 28 weeks plus 1 day, and that was on the 18th of October 2018. She weighed 695 grams, and now she weighs a kilo. I think okay for just a second. There's science behind having contact with your preterm baby. Their heart rate and breathing is so much more stable, and I think it shows us that it's very important for these babies medically and for their development in the long term to have early contact with their parents.
So there's a little clip from Dr. Sarah Bates, who's a consultant paediatrician neonatologist in Swindon, which is over towards the west of England. She's one of those in the UK who've been amongst the forefront at rolling out delivery room cuddles. Thanks for that clip. So the outline and concept of the whole practice, we're here trying to offer and facilitate the chance for a baby and the mother to have a cuddle before the neonatal unit admission. So a very simple idea, and we don't need to complicate it beyond that, but it's important to look at the intricacies of it, the practicalities of it, first and foremost, the safety of it as well. But fundamentally, we need to know what parents are thinking about it, and that's going to be a main feature of what I'm going to present today, the parents' feedback on the cuddle. So we're talking about allowing the baby to have a cuddle in its parents' arms, usually the mothers, but let's not forget the fathers as well. Instead of just showing, as we've often traditionally just done, we've given the parents a very cursory, brief show before we whisk the baby away to the neonatal unit. I believe we can look towards trying to practice this frequently. We should think about being able to do it wherever and whenever it's possible. I believe we can practice it irrespective of birth gestation. So any babies we're considering eligible for admission to the neonatal unit, we can consider whether it can be offered to that baby and those parents. So I'm going to focus primarily in this talk today on offering the cuddle for extremely preterm babies. That's not because I'm forgetting the older, more mature preterm babies, not at all. But I think and firmly believe if we can focus on the practicalities of it for the most premature babies, then we can do it for all premature babies. As a brief overview, I'm going to present a little bit on the safety of the practice, the background to it, the concept, why we should think about offering it. And then we're going to look at the practicalities of how we may offer it in our routine practice and how it may fit in with our usual unit practices for resuscitation and stabilisation and ventilation. And importantly, as I've just said, we need to hear what the parents themselves are thinking about this practice. So we're in a new era, aren't we? Family-centred care. The family needs to be put at the forefront of the baby's care for the baby to do best. So the approach is rooted in the belief that optimal health outcomes are achieved if we put the baby's family right at the front in providing the emotional, social, practical and developmental support that the babies need. So it's an approach to the planning, delivery and evaluation of healthcare that is governed by mutually beneficial partnerships between many of us as the healthcare providers, but also the patients, parents and families. So we're aiming to promote a partnership in all that we do for the baby's journey through the whole of the neonatal unit between the parents and the healthcare professionals. So I firmly believe we can extend this concept of family-centred care right back to the moment of birth, right back to the delivery room. I believe that optimal health outcomes will be achieved when we invite the parents to be and permit them to play an active role in providing that care, emotional, social and developmental right from birth. And I think enabling a delivery room cuddle is an ideal way in which we can promote that partnership between parents and ourselves as doctors and nurses in the care of extremely preterm babies right from the outset. So if we can try and allow for mums and dads to have the chance to cuddle their baby before the neonatal unit admission, that will begin that partnership. And I believe it can have many benefits. So if today, I hope I'll be able to show that the practice is indeed feasible. It can be done safely and it is beneficial for both babies and parents and the staff as well, I think. And I'll propose that we should really think to be offering it and practicing it for most preterm deliveries. So why should we practice it? We already know the big benefits of kangaroo care and direct skin-to-skin contact. They're multifold and have been well described and extensively published upon. So what we see, and there's a big literature now to support the beneficial physiological and behavioural effects on the baby, such as better temperature control, better sleep patterns, augmented and earlier breastfeeding rates and prolonged breastfeeding, earlier discharge for the babies, and better growth and development, which extend beyond the neonatal unit discharge. There are also psychological benefits. So parents report more positive feelings to the baby, lower maternal stress, and more confidence in meeting baby's needs. So while for extremely preterm babies, the delivery room cuddle, as we practice it, is not usually involving direct, complete skin-to-skin contact, because our babies have already been put in polythene bag and swaddled in blankets. Some of the benefits may well be similar, and I believe we'll have more evidence of these over the next few years. Importantly, the European Foundation for the Care of Newborn Infants, which is a parent-led organisation, they've advocated for early skin-to-skin care for babies, and they say it's of particular importance for very preterm babies. So they recommend initiating skin-to-skin as early as possible as standard care. We know that the first minutes and hours after birth are really important for the formation of a tight bond between mother and infant. And this concept of a so-called early sensitive period, it was actually introduced more than 4 decades ago. We know that this period is characterized by a special neuroendocrine situation. It's probably mediated by oxytocin, probably also prolactin as well. But what we do know is that it's a very unique period of increased maternal sensitivity and responsiveness. If we can facilitate contact in this period, it may improve the quality and longevity of mother and preterm baby interaction and increase the chance of secure and long-term attachment. So why should we practice delivery room cuddle? Fundamentally, mothers and fathers, they want to cuddle their newborns. Cuddling the newborn baby is instinctive for parents, and that's irrespective of gestation. Parents actually want to hold the baby close to them. We know that abrupt separation and removal to the NICU of the baby, it's certainly traumatic for parents, certainly traumatic for the mother who's carried that baby for many months already. But who knows, it may well be traumatic for the baby, and it probably is. If we can offer a calm and supervised initial cuddle, I believe it's a marvellous opportunity for us to provide initial reassurance at that time directly to the parents, for us to meet them, for parents to meet the baby, for baby to meet the mother externally, and to form an initial bond with them. And it's a chance for the baby to feel a first loving embrace, hear the parent's voice directly for the first time. Parents can then touch and kiss the baby, and we can try and facilitate the family getting the first photograph and video together. What's clear is that on the neonatal unit, once they're admitted, the premature baby is immediately effectively incarcerated and shackled to multiple items of equipment. If we don't allow the cuddle early before the neonatal unit admission, then it's invariably many days, if not weeks, before a first cuddle becomes possible. The initial cuddle is especially important, I believe, for extremely preterm babies, because they're at the highest risk of dying. And often we can't predict right at the moment of birth which ones are destined to unfortunately die. And it's a real tragedy if a first cuddle is only offered when the baby's dying or terminally ill, if they've collapsed suddenly, for example, and then we call the parents in urgently and then offer them that first cuddle. If they've never had a cuddle before, they'll be really anxious and really traumatized. And many of them, and I've seen it many times over the years, many of them will feel too distressed to be able to hold the baby at that time. And who knows, that may live with them as a guilt feeling later on, which they may find very hard to come to terms with if they've not held the baby at such a time. So we can avoid that by offering a cuddle when the baby's stable and stabilized in the delivery room. And it's a real disaster if the baby will die suddenly never cuddled. So let's try and avoid that. How common is the practice at the moment? Well, there's actually very little literature out there to show about early cuddling in the delivery room. One of the few papers I could find, there's a handful which go back to 2014. And this is one of the first ones, which was a survey done, published in Acta Pediatrica. A survey done about 10 years ago in 2 Swedish hospitals, tertiary neonatal hospitals in Sweden. And it was studying when first-time events occurred between parents and preterm babies. And one of the things they asked about was, when did you first get to hold your baby? Did you hold the baby in the delivery room or operating theatre? And actually, bearing in mind, these were more mature babies than ones I'm describing. These were 28 to 33 weeks gestation with a median of 32 weeks. Only a third of mothers and a similar number of fathers were able to hold the baby in their arms in the delivery room before the neonatal unit admission. And the authors in this paper said one explanation may be that some infants need immediate intensive care treatment, and that might be the reason why they didn't get initial holding. However, it's also possible that staff followed what conventional traditional guidelines for medical nursing routines in the baby's initial care and did not consider the importance of that first contact between parents and infants, even if it were possible. What about in the UK? There's a similar study looking at first-time experiences and moments with preterm babies, which is published in BMJ Open, so an open access paper. This was published in 2013. It was from a survey done of 32 mothers and babies born between 24 and 32 weeks gestation in 3 tertiary units over a 6-month period back in 2011. And in this paper, not a single set of parents were able to hold or touch their baby until after they'd been admitted to the neonatal unit. And for many of them, the first time they got to hold the baby was often weeks down the line, weeks after the birth. And some of the quotes from parents given in this paper, I've listed a few of them here. So one mother said, "I just wanted to pick him up and hold him, but you couldn't because he was on the ventilators, and you couldn't hold him for quite some time because of him being on that ventilator and all the tubes hanging out of him. It was heart-wrenching that he was just going to be taken straight away, be born and taken away. I knew it was for his own good, but I still hated it." Another mother said, "You've waited so long," so when the baby finally got out of the incubator. "So yeah, holding them was amazing." Another mum said, "It's such a big thing for the babies, for mums to hold them." Another mother said, when she eventually got to have that hold a couple of weeks down the line, it took about half an hour to get him out just because of the wires, but no, it were nice. So my conclusion for how common the practice is, it seems to be unclear from the literature, but it seems to be the exception rather than the norm, even at the moment. I think it's becoming more frequently practiced over the last couple of years. For my own practice, it's been my personal practice going back about 2 decades. And it's great to see it is becoming routine practice in at least a handful of UK centres now. What is clear is that it's unanimously supported by neonatal nurses and midwives when it is practiced. So why is it still not routine practice? I think fundamentally, we've never done it traditionally. It's never been the done thing. We've always had this urge in us as doctors and nurses that we must dash the baby to the neonatal unit. That's been the real imperative. It's not been helped by absence of literature as well. So that's starting to change now, thankfully. We're starting to see papers appearing of the safety, the practicalities of it. And I think that's one of the main reasons. Maybe there's been big concerns regarding the safety of it, the lack of any supportive safety and outcome data for the babies who have experienced the delivery room cuddle. But there's been a real lack of feedback from parents as well, which is crucial. We need to listen to what parents may need and what they may want. And up until very recently, there's been actually no published guidance for the practice, how we may do it, how we may roll it out, and the practicalities of it. So that's, as I say, changing now. We can't adopt it unless we're sure in our minds as we can be that we're not going to be putting the baby at undue risks. And there are potential real risks here that we need to consider and prepare for and avoid as best we can. So the baby may be made unstable, and the tube could get dislodged if the baby is intubated. That's a possibility during cuddles. It certainly happens on resuscitors. It happens during transfers to the neonatal unit. So we need to do our utmost to try and avoid any inadvertent tube dislodgements. Could the baby be put at risk of hypothermia, hypoglycemia, or acidosis if we're, by giving the cuddle, if we're delaying the admission? That's a theoretical risk as well. I believe that any such risks of short-term safety issues should be negligible because we're really only talking about delaying the baby's admission by a matter of several minutes. Crucially, intensive care is ongoing while the baby is back with his or her mother, and it's up to us as the neonatologists and nurses to assiduously supervise that whole process. So I think a common misunderstanding of giving delivery room cuddle is that we just plonk the baby on the mum and then leave them to it for a while. That's absolutely not what we're talking about here. We must be providing and guaranteeing that ongoing intensive care for all those precious minutes that the baby is back on the mother's chest. I think certainly in our own practice and for those that have adopted it, there's pretty unlikely to be a randomised controlled trial. I don't think we could ever sign up to one now that we're offering it as a routine on my unit. However, maybe other units that are more in equipoise may feel that's reasonable. But again, you'd want to be sure what parents think about it. And having heard the feedback I'll present to you, what parents think about it, I think an ethics committee may have their own issues to raise about whether it's ethical to not allow it when a lot of units are practicing it routinely. However, that's for discussion. There was an interesting recent randomised controlled trial which provided some data from Cologne in Germany, which I'll present here. So it's about, I think this is about the only randomised controlled trial you'll find in the literature, to my knowledge. This was only published in 2019. So this was from Angela Cribbs and colleagues and Katrine Mailer, who's first author on the paper. And they randomised 88 babies. And the groups here were either 60 minutes of delivery room skin-to-skin contact with the mother, or else 5 minutes of only visual contact and no holding or kissing or minimal touch. The babies got randomised at around 45 minutes postnatal. So already 45 minutes have passed for both groups here. And it was following their usual stabilisation, which included CPAP if needed, LISA if needed. So that's maybe better known as MIST for some of you, less invasive surfactant administration. And these babies had IV access placed and IV glucose drip placed as well. So they actually had a side room, which was set up like a mini intensive care unit. So not quite delivery room in many respects. And also they excluded babies if they were intubated or if they were needing more than 40% oxygen despite surfactant administration. And the outcomes they chose, they looked at short-term measures such as temperature on admission. And very interestingly, they found that the temperatures on admission were actually slightly higher, but significantly so in the delivery room skin-to-skin care babies compared with the babies who had only 5 minutes of visual contact with the mothers. Now, their primary outcome was an interesting one. They looked at 6 months down the line, what was the quality of maternal and infant interactions. And the way they did this, they took 4-minute long video clips of the mums with their infants when the babies were aged 6 months corrected. And they had the videos rated by blinded raters to judge the quality of the interaction. So basically how well the babies were bonding and the mums had bonded with the babies. And they actually found a significant difference, interestingly, for the mums who'd had the early skin to skin compared with those who'd only had the 5 minutes of visual contact. There were no other differences in neonatal course or short-term outcomes. So really fascinating data and suggesting that maybe, even from very brief periods here, long-term benefits. So what about the safety and extremely preterm infants? So if I just go back to that one, they didn't include 22, 23, 24-week gestation babies. In fact, the mean gestational age of babies in that randomized controlled trial, they were more mature babies, so 29 weeks was mean. So what about the extremely preterm babies? We've practiced in Norwich, variably I must say, but increasingly so over more recent years, for all gestations. So I thought it was important we look back at our own series and experience retrospectively to see what the short-term safety outcomes for the babies we were offering Delivery Room Cuddle to for were. So my question was, does offering Delivery Room Cuddles to mothers of extremely preterm infants, does it significantly delay their baby's neonatal unit admission, or does it affect their admission temperatures? As I say, this was a retrospective review and it went back over a 12-year period, almost for as long as I was in Norwich. We only got our electronic summaries kicking off in around 2006. So because I had to review about 400 discharge summaries to identify the babies who'd had a cuddle at birth, I was looking for the resuscitation details and seeing where it said or recorded that the baby had been taken to its mum for a cuddle. And we wanted to compare it in a case control manner with extremely preterm babies who were well matched but who'd not had a cuddle, and where it was documented that they'd only been shown to the parents before neonatal unit admission. So we had two groups here, cuddled versus just shown, and we matched them as best we could for gestation, gender, delivery mode, and multiplicity as well. And we looked at the admission times and temperatures and survival to discharge. So altogether, there were almost 400 babies admitted over that 12-year period of less than 27 weeks gestation. We focused on the inborn ones because essentially those were the only ones that had any chance of having been offered a cuddle. So just under 60% of them were inborn. And out of the 233 inborn babies born at less than 27 weeks gestation, we had a documented delivery and cuddle in 27 of them. Now, that was almost certainly an underestimate of those that did get a cuddle in the delivery room due to lack of documentation. But we wanted to be sure from the documentation that I'd have been cuddled or just shown. All but one of these 27 babies was intubated at the time of the cuddle. And I guess that reflects slightly historic practice now where we would routinely intubate babies in the delivery room at less than 27 weeks gestation. Things are very different now, I'm sure, for many of your units. We try and avoid automatic intubation, certainly for the 26, 20, 25 weeks gestation, and we'll give them a go on CPAP initially. So most of these ended up being intubated. And here are the results. So they were actually well matched for the gestational age and birth weight as expected, because that's what we were trying to do. So the column here is the babies who got the cuddle, and you can see that some of them, the range was right down to 22 weeks and 5 days gestation for one of the babies. They were all under 27 weeks gestation, and they were similar in the ones that were shown only, no significant differences, similarly for the weights as well. So the outcomes we were interested in was how old were the baby on admission to the neonatal unit, and essentially there was no significant difference, certainly not statistically. Slightly earlier admission, interestingly, in the ones that had the cuddle in the delivery room. So some of them were admitted as early as 11 minutes postnatally in both groups, but you can see in the cuddle group, some of them as late as 41 minutes, the range. There was no difference in admission temperatures, importantly. This was one of the main outcomes we wanted to look at. So no significant difference. So we've got median and range of temperatures. Again, slightly historic series here, and I'd like to think our rates of admission hypothermia, in fact, I know our rates of admission hypothermia are lower now, thanks to recent measures we've introduced, but no difference between the two groups. And again, survival to discharge, there was no difference in between the two groups. And those data are reported in our recent paper. So a conclusion from that retrospective review was that offering parents a brief delivery room cuddle of the extremely preterm baby prior to the neonatal unit admission, it doesn't significantly delay the neonatal unit admission, nor does it adversely affect neonatal admission temperature. So let's move on to which babies should we think about offering the cuddle for? And the simple answer to that is most babies, I think most babies of any gestation should be eligible to have a delivery room cuddle, or at least be considered for it. So simple answer, but let's go down into the detail of it, because there are some babies where it's probably not indicated, or definitely not indicated. So clearly, if the mum's under general anaesthetic and she's had a caesarean section, then she's going to be in no fit state. It's obviously unrealistic to try and arrange a cuddle there. However, some mums are awake during caesarean section, and it can and does happen there if at all possible. Sometimes the mum's acutely unwell immediately following the delivery and needing stabilisation herself, and that's not going to be appropriate to try and arrange for the cuddle to happen there. What about babies who've got expected or unexpected difficult airways or congenital airway malformations? Again, it's contraindicated, I believe, for those babies. Similarly, if the baby's needing urgent ongoing resuscitation, or it's prolonged, for example, needing volume or blood products or inotropes, things that can't be done in the delivery room, where the baby needs to be urgently admitted to the neonatal unit. I think more debatable are babies who've got, again, expected or unexpected congenital heart disease, mostly expected these days because of the fetal scanning. Should a few minutes be allowed with the mum? Is it going to compromise the baby by delaying the admission for a few minutes? We could debate that one. I personally don't believe it's an absolute contraindication, and there may be benefits, certainly for mum and baby, for a few minutes extra in the delivery room. What about encephalopathy, where the baby needs active cooling? Again, it wouldn't be an absolute contraindication not to allow a few minutes cuddling with the mother, irrespective of severity of the baby, unless there's a need for ongoing urgent measures. I think more challenging situations, but definitely not absolute contraindications, are where there's an awake caesarean, as I've just mentioned, but also where there's twins or triplets, multiple deliveries. They pose their own challenges, but definitely not an absolute contraindication. So I'm coming on to, I think, what's probably the most important part of this talk, if anyone needs convincing why it's important. We need to hear what parents think about the practice and the cuddles. So again, I did this from our own series of mothers who I knew had cuddles in the delivery room. We went back and asked them. So we did a questionnaire survey. This was done back in June 2018. And I went right back to 2006 for that 12 to 13-year period of mums that I knew had a delivery room cuddle. Altogether, we invited 22 mothers to feedback via a web-based questionnaire their thoughts and experiences of delivery room cuddle. We had to exclude 9 mothers because of bereavement. This was more a service evaluation, so I think if we'd wanted to include bereaved mothers, which would have been really interesting, but we weren't able to as a service evaluation. I think that would have needed a formal ethics approval. Very sadly, we had to exclude one mother who'd herself died several months after giving birth to a 25-week gestation baby. She died of her own illness, which precipitated the delivery. So altogether, we had responses from 12 out of the 22 mothers who had written to. So the response rate, just over 55%. Of these, you could see we had quite a few multiples. So 2 were mothers of 23-week twins, 2 were mothers of 26-week twins, and then 8 were mothers of singletons. So some of the questions we asked, and these were the potential responses. Can you remember being given your newborn baby to cuddle in your arms in the delivery room before he or she was taken to the neonatal unit? So remember, we were going back as long as 12 years when we were asking this question. And 10 out of the 12 who responded to that question said they could remember it, and that they remembered it vividly. We asked, how important was this first cuddle to you as the mother of a very premature baby? We asked them to rate it on a Likert scale between not at all important or extremely important, and these were the responses we got. So the vast majority of mums felt it was really important to them as a mother of a very premature baby to have a cuddle. I'll talk about this one who didn't rate it highly shortly. We asked what their feelings were at the time of the first cuddle. And some of the responses we got, or they were able to identify with, were whether they felt scared at the prospect of holding the tiny baby, whether they felt reassured or relieved when they were giving the baby the first cuddle, and whether they had, what were their feelings were. And these are the responses we got. Some of them, many of them had intense feelings of pride and love. Two of them made other comments. I was grateful for the cuddle, but stressed at the time. Another mum, and this is the one that rated it as not that important to her. She said, I was keen to hand the twins over to the doctors and nurses as I was nervous and worried that they could not breathe very well without a ventilator. This, I think, is really good feedback, and it highlighted us actually. It told me that these parents weren't properly prepared for the cuddle if they were thinking that we were delaying the neonatal unit intensive care admission, if we weren't ventilating the baby properly. So these are all the important aspects of reassurance and preparation for parents that we need to bear in mind if we're going to start offering the cuddle. So we asked a more general point to these parents. How important do you consider it that neonatal doctors and nurses try to offer, as far as possible, mothers of newborn premature babies an initial cuddle in the delivery room before the baby is taken away to the neonatal unit? So again, we asked them to rate on a scale 0 to 10, and these were the responses. So again, the vast majority of respondents thought it was really important as a general point that parents should be offered the cuddle. Then we asked, was there anything that the doctors, neonatal doctors and nurses did during the cuddle which helped you or reassured you? So one mum of 23-week twin girls, she replied, yeah, they said to us, here are your daughters, and they told us to give them kisses, and that they were doing the handheld breathing for them, and while I had my cuddles before they went to the neonatal unit. So that mum remembers that, remembers it helped reassure her. Other parents reported, they said, how handsome my son was and how I seemed to look comfortable and natural holding him despite the chaos. Another mum said they were telling us and reassuring us that they were fine and breathing and it was normal for a baby that size not to cry. Another mum said making the initial cuddle as close to as if it could have been had he been born at full term to make it feel normal for me was great. We also asked some other responses we got here. So one mum said, would have been nice to have held them a bit longer, as I didn't get to hold them again until 1 week later, but I understood why. I think one of the limitations of the survey that we did and also the review that we did, it wasn't well recorded, if at all, in the notes how long the mums had cuddles for. So for most, it probably would have been just a matter of a few minutes going all those years. Again, when we asked, another mother replied, what could have been done differently? This mum said, and this is the mum who I felt hadn't been prepared properly, so further comments from her. It was very quick, but I just wanted medical attention for her, my daughter. Looking back, I'm glad I got the cuddle in case I lost her, but I just wanted them to help her. That was more important to me. For me, I was very stressed, and in hindsight, I'm glad I held her briefly while she was wrapped in a towel. But I've often wondered, why on earth was I allowed that when she needed so much medical attention? It makes me panic to think I took any time away from all the serious medical help she needed. But if I had lost her, I'm happy I had that cuddle. Then another mum said about the cuddle, it was incredibly important as I did not get to hold my son again for 2 weeks as he was too sick. That cuddle helped to initiate my breast milk, and I was able to express and eventually breastfeed my son when he was stronger. So this is Josie. She shared some great comments, mum of 23-week twins. She was so delighted that she'd been offered and had a cuddle. She said it was so beneficial to hear my daughters cry and stop to have that first cuddle was what we needed, as I knew I wasn't going to have another cuddle for a while. To have that first cuddle, I felt like a mummy. And I was very thankful because I didn't get another cuddle until 24 days later, I think it was, which again was very emotional to see them and touch them at that time. But maybe it was that very first touch was what we all needed, both me and my daughters, knowing it was going to be a really tough journey ahead. Thankfully, we are the lucky ones. Didn't think that at the time, but maybe that was part of what helped them survive. So that's it from parents. We can now talk a little bit about the practicalities of facilitating the delivery room cuddle. I've alluded to some of the key points already, but it's good to reiterate them because there are some really important key points here. First and foremost is the timing of it. The timing needs to follow the delivery room stabilisation or resuscitation if it's needed. So the point is we need to make sure the baby's as stable as we can get them. And the window for offering that cuddle begins at the time when traditionally, or even now if you're not practicing it, it's the time when we'd be leaving the delivery room to head for the neonatal unit. And that's the time when we should be able to take the baby to the mother, back to the mother, before we depart for the neonatal unit. So remembering that the safety of baby and the mother is paramount throughout this whole process. Another fundamental point is that we are providing ongoing intensive care, and that's provided by the whole team, led by the most senior member present in the delivery room. The duration of delivery room cuddle is variable. It'll vary with your experience. For our own practice now, it's frequently up to 5 to 10 minutes at least. Usually 10's upper limit. In the early days, and I think when people are first starting out and feel nervous about it, it's perfectly reasonable just for a couple of minutes. Mums may be anxious for longer than that. The team will initially be feeling anxious because it's what we've never done before. But I think with practice and experience, you'll be far more comfortable allowing it and seeing how stable the baby is and how much it's appreciated by the family for more than just a couple of minutes or a couple of seconds. Again, communication is the other key. Good communication is really essential, and that's first and foremost with the parents and amongst the team, but also with the rest of the wider team. So midwife, obstetrician if they're in the room, anaesthetist if it's a theatre situation. So we need to brief the mother properly before bringing the baby over to her. Now, ideally, if we've got time to counsel them antenatally about the whole what to expect when your baby's admitted to the neonatal unit, that's when it can start antenatally in the ideal situation. But sometimes we don't have the luxury of that. But we should still brief the mum, the dad, before bringing the baby back over to them. So we need to explain beforehand what will happen, explain during the cuddle what is happening. We need to make sure we get the go-ahead from the midwife or the obstetrician before the transfer. And it's really important, I think, to have a calm, reassuring approach with parents throughout the process. We want to encourage the mum to touch and kiss her baby during the process, to talk to him or her. We should offer to help the family take those photographs. We can take photos for the parents using their phones, nothing to stop us doing that with their permission. Get a little bit of mobile video footage as well. We mustn't forget fathers in the process as well. So prior to bringing the baby back to the mother for the cuddle, we want to check the baby is stabilised. We want to make sure we've got saturation monitoring underway. We want to make sure the airway is stable. If the baby's ventilated via endotracheal tube, we want to make sure that's securely in place. We want to be heart rate monitoring and saturation monitoring as well. We want to make sure the baby's stable on whichever mode of ventilation it's on, whether that's non-invasive or invasive. We want to make sure the temperature is satisfactory. There's no point in bringing the baby over if the baby's already hypothermic. We should have taken some measures to address the hypothermia on the resuscitator. Ideally, and these days, this is what we're routinely practicing in our unit, we have a continuous skin temperature probe in situ, and that is placed on the resuscitator within the first few minutes of delivery. So we've already got a continuous temperature readout, and that's been one of the really important things we've introduced, which have helped lessen the rate of the incidence of admission hypothermia on our unit. We need to make sure there's no contraindications to the delivery room cuddle, some of which I mentioned before. So we need to make sure the whole team is updated and knowing what to expect. Remember that if it's not been routine practice in your units, most of them will never have seen or even thought of the concept of a 24-week gestation baby receiving a cuddle. So we need to make sure the whole team is prepared and reassured for what to expect and what we're planning to do. Again, coming back to it, we must make sure the parents are updated and mentally prepared as to what to expect. Again, coming back to this fundamental concept, we're there to provide ongoing intensive care during the whole cuddle process. Babies themselves aren't fussy as to how they're ventilated during the cuddle. Any mode will do for them. Just continue whatever is your normal unit practice, whether that's CPAP from delivery room, whether it's babies need intubation or not, or whether it's high flow from the delivery room. All these are quite possible and perfectly reasonable to be able to facilitate the cuddle while the baby's being ventilated by those modes, invasive or non-invasive. So the cuddle should proceed with the baby in mother's arms with those same ongoing ventilation needs, whichever it is. So just some examples here. So this is a baby who's been born during a wake cesarean section. It's with courtesy of Dr. Sarah Bates, who published this picture in Infant magazine. So here you can see the cuddles being facilitated and they're doing simple mask CPAP for the baby. So more mature baby here of 31 or 32 weeks gestation. Most of those in the series I've described were intubated. So here's a little 23-week twin who is being hand ventilated by TPs by a neonatologist with the baby in the mum's arms. So you can see the baby is swaddled. Underneath there's a polythene bag. The tube's nice and secure. The baby's nice and fast asleep and the mum's happy because the baby's in her arms. So we're doing all the ventilation. We're doing our first updates with parents, reassuring parents, chatting to them about what to expect and reassuring them how well and stable the baby is at this point in time. So thermal support is really important. I've already mentioned the baby is implanted and swaddled in the way we practice it. So it's not direct skin to skin. I think that may well come in other units in the future. Saturation monitoring is underway and we've ideally got skin temperature probe in situ throughout. If needed, we can deploy the transwarmer. So just to show you some of the kits that we have and we are using routinely. So this is the several devices available. This is one by Philips, which is the continuous monitor for monitoring oximetry and temperature. So we've got oximetry probe and a cover for it to block the light. And then the temperature probes are simple to place. It's placed within a matter of seconds and plugs into that transportable device. If the baby's intubated, then it's ideal that we've got continuous end-tidal CO2 monitoring underway as well. So moving on to introducing the practice in units that aren't routinely practicing it. I think it's really important to have the whole team on board before we suddenly start practicing it. So then no one's taken by surprise. The practice rolled out in a consistent manner as well. So there should ideally be a local guideline in place for practice, for delivering cuddle, for which babies are eligible, for which babies should be contraindicated, how it's done. I think simulation, we do simulation for a lot of things these days in training, but it's also really good training for delivery room cuddle as well. And I think if units can identify local champions, so medical and nursing and midwifery leads to champion the process, and these will help disseminate knowledge and solve problems and troubleshoot issues, and also increase the unit's enthusiasm for the practice. And I think as units start adopting it and practicing it more and more as routine, it's really important to audit prospectively your admission times and temperatures and glucose and pH, etc., just so you can reassure yourself with the safety data. And we've now got published literature. So this is a summary, one of the figures from the paper we published in Acta Pediatrica just a month or two back. So this paper, I'll give the reference at the end. It's freely searchable on PubMed anyway. If you just search for delivery room cuddle, you'll probably get it as first hit there. And it's the first paper, we're proud of it because it's the first one to really give any detail of the process for how to offer a delivery room cuddle. So credit to my co-author, colleague, Dr. Paul Corley, who's on the call today and will help answer any practicalities questions at the end if anyone's got any specifically related to that. But I think these little summaries will be great for units that need to write a guideline and as to how the practice can be adopted, which babies are suitable, assessment prenatally, and how this process happens. So I think in summary, there's two main ways it can be done practically, and we do it variably in our unit. So for some of them, and it depends whether the baby's in theatre or not, it can be done via the transport incubator with long enough ventilation tube if the baby's been intubated. For the babies born in delivery rooms, not in theatre, more often we'll wheel the whole resuscitator over alongside the mother, and then with the baby still connected, if it's needing ventilation or non-invasive ventilation, we can then place the baby on the mum, still connected to all the resuscitator equipment. So I mentioned simulation. So this is a really nice tweet from Sarah. just to illustrate that. So these are two neonatal nurses here, and this is a simulation preterm baby doll. And they were able to practice this and rolled it out so that they were very comfortable with the process of how to do it, who's doing what to say. So simulation's a great way of preparing for it and getting the whole team familiar with Delivery Room Cuddle. So the focus of my talk's been on offering Delivery Room Cuddle for extremely preterm babies. And I believe it is possible for even the most extreme preterm babies, and none should be excluded. As I said earlier, I think any baby we're considering eligible to admit to undertake intensive care with, we should be offering Delivery Room Cuddle for, or at least considering eligibility for. And just to show you nicely here, this is a 22 weeks and 6-day gestation baby born back in July 2018, 530 grams. And this is with the very kind permission of this little baby's parents. I'm really honoured to have the mum of this baby on the call today. So if there's any specific questions any of you have for Sheila, the mum of this little baby, she'd be more than happy to answer them. And it's worth thanks to Sheila and her husband, sorry, her partner, that we're able to share with you this case today. So this little boy is called Nicodeme. This is the history of what happened in the delivery room and the timings of it, just to illustrate. This is a typical set of timings here. The baby, little Nicodeme, he came out in good condition. He was attempting to cry. We practiced delayed cord clamping for 60 seconds as he delivered, and then he was brought over to the resuscitator. So on the resuscitator, he seemed to be in good condition. He was active and moving, showing spontaneous respirations and a good heart rate already at 2 minutes. So we electively intubated him at this point. That was done by one of my colleagues, registrar, in the delivery room. By 5 minutes, the SATs were still low, persistently so, despite 40% oxygen. So we pushed up the oxygen requirement there, and he pinked up a bit. We increased the PIP. We were doing hand ventilation via TPs here, and his heart rate had picked up nicely to more than 120 by 5 minutes. So then, after drawing the surfactant, it's a pig-based surfactant we mainly use in the UK. So we gave Curasurf 120 milligrams at 12 minutes. This is something that happens, unfortunately, frequently. The tube dislodged during fixing, so it needs to be refixed. And it was another 10 minutes there delaying the process before the baby was in a stable enough condition, and we were happy that the tube was secure before we could move the baby over to mum. So it was 26 minutes there when we'd briefed mum already and made sure she was happy and knew what to expect. So we wheeled the resuscitator over alongside her bed for her to cuddle her baby. First meeting postnatally. And then Sheila had an unhurried cuddle, which lasted 9 minutes. It was around 9 minutes in total. All the time, we were ensuring the baby was guaranteed the ventilation, was attendant neonatal nurses and doctors. And this was one of the nicest deliveries I've ever been at. And I'm honoured to be able to show you the little video clip, thanks to Nicodeme's dad, who this was recorded on his phone, and he's very kindly, as Sheila, allowed us to share this today with you all. So it's only a minute or two long, but hopefully it'll give you an idea of what's going on in the delivery room. Some of the things you'll hear are not great. You'll hear a lot of beeping going on, and it's amazing just looking back how noisy that is. And I think when we examine our practice, these are all things we can try and reduce for the benefit of the family and the babies in future. But here it is as it was back in July 2018.
You've grown in you would have been huge if you'd gone all
So it's early days. So what we'll do when we get round, we need to put some special lines in, some tummy button, so we can give him some sugar solution and then some liquid feed as well. And really important will be, are you planning to breastfeed? Have you thought about that? Yeah. That'll be really crucial. Okay. Get worked on overnight. Good weights as well. We'll weigh him when we get around. As soon as we get around, we'll be able to weigh him. Oh my God, yeah. So again, renewed sincere thanks to Sheila for allowing us to share that today. But I hope that gives you an idea of just how calm it was in the delivery room and how nice it was, and very special moments for the staff as well to be there right at the heart of sharing those most precious family experiences. Just to continue the story following Nicodeme's admission, it was about 35 minutes by the time Sheila had finished cuddling him. Dad was then able to get a cuddle for a few minutes while we carried on. And it's 40 minutes before we departed to the delivery room in the transport incubator. And he was admitted to the neonatal unit a minute after that. We're right next door to our delivery ward. His admission observations, so temperature 36.0. The first glucose measured was at 55 minutes postnatal, that was 3.1. His pH was good, lactate normal. So certainly no compromise to this little 22-week gestation baby from having had quite a nice long cuddle with his mum and dad. By chance, I was down in, so Nicodemus spent about 3 weeks on our neonatal unit in Norwich before being transferred to a neonatal unit closer to home in London. And I was down there giving a talk, just happened to be down there, and saw all the little comments that the parents had done for World Prematurity Day. And I happened to see one from Sheila, because that was on the wall as well, and Nicodemus had been transferred back down there. And this is how Sheila described prematurity: the storm before the calm. And I often like to think as Delivery Room Cuddle as being the calm before the storm, before the calm for these tiny little, extremely preterm babies. And got home at last, and there's a picture of him at home, a wonderful achievement. And Sheila made these comments when she was reflecting on her Delivery Room Cuddle. She says, "I was thinking about the cuddle this morning, and that postnatal fatigue was so tangible even now. But considering how unclear the outcome of his birth was, I can honestly say that cuddling Nicodemus was probably the most encouraging factor in me deciding to express milk for him." So just to summarize, certainly from the parents' perspective, virtually all parents appreciate the Delivery Room Cuddle greatly. They want it, and I believe they should be offered it. Good communication is really vital. Closely supervised, I believe it's safe. And I think with the inexorable move towards increased family-centered care, we predict it will in time become standard care at birth for most babies born preterm. And I think it'll become an expectation of parents as well, especially when they hear other parents are being offered it elsewhere. They'll have a right to question, why didn't I get that? And I think, we've only got one true birthday in our whole lives, and there's only one true birthday time when you can have a birthday cuddle. So let's make the most of it. It really is irreplaceable. We can't really discuss anything these days without touching on the fact that everything's altered in this COVID era. So again, we need to reflect on what's it mean for Delivery Room Cuddles. So we do give a paragraph or two to this in our Acta Paediatrica paper. But in summary, we're all familiar with some mums who are coronavirus positive. They've been separated for the babies for weeks. And that's bound to have a big negative effect on their feeding and bonding. It's inevitable. However, the evidence we've got to date, and the growing evidence, suggests that the risk of perinatal transmission of the SARS-CoV-2 is low. And our current guidance we've got in the UK, from the Royal College of Obstetrics and Gynecology, from the British Association for Perinatal Medicine, and from the Royal College of Paediatrics and Child Health. Their guidance actually gives useful reassurance that despite the lack of a solid evidence base to date, it's important to emphasise that in all reported cases of newborn babies getting coronavirus soon after birth, the baby was well or had minimal illness. So in the UK, although there's no current guidance, evidence or recommendation against continuing to practice or offer Delivery Room Cuddle for COVID-19 positive mothers as per usual practice, it's really important to follow your own safety guidance and adhere to PE guidance as well. I think in summary, if the parents are asymptomatic and it's confirmed negative, then certainly there should be continued facilitation of Delivery Room Cuddle. It should be safe, provided there's adherence to the usual appropriate personal protective equipment and local infection guidance. I think if the mum is symptomatic or confirmed as positive, then it may at the moment seem prudent to avoid routine early skin contact until more is known about the risks of the viral transmission to the most extremely preterm infants. However, countering that is an important real consideration. If we don't allow Delivery Room Cuddle to COVID-19 positive mothers, term and preterm, it is entirely possible that 1% of those mothers could die never having held their baby. So I just want to end with the final say from parents. You don't need to take it from me, take it from parents. So this is what Josie said again. She said, I was and I'm so grateful to have had that first cuddle, and luckily I got that chance. I really hope this becomes the normal thing to have straight after delivering your baby. It's such a powerful connection you have, even at that early on time. And I feel that's part of why the girls have done so well, because of as much skin to skin as I could do from the minute I could. And I mentioned when we survey parents, we excluded bereaved parents, but I was presenting this talk about a year or so ago up in the northeast of England, and one mum contacted me via Twitter, unsolicited, but these were her comments on hearing my talk about the Delivery Room Cuddle. She was a mum who'd had very extremely preterm twins, and she said the following: I never got to hold Leo, one of my twins, until it was time to say goodbye. So hearing about this Delivery Room Cuddle really struck a chord with me. I think it's such an important and fundamental thing to have a cuddle, which is expected when you have a full-term baby. But when they're born preterm, it's often something parents feel robbed of. I was very affected by that with Leo, and again with his twin brother Oscar, who did survive and was born 4 days later. I felt a lot of guilt and very angry at seeing those photos in delivery rooms of happy mums with baby on their chest. When I heard about this, I thought, finally, this could make a huge difference to parents and baby and the mental health of parents. Being able to reduce that feeling of guilt and grieving over what they've not had with their pregnancy and delivery is going to make a phenomenal difference. So these were really important unsolicited comments that came from Lottie, and she runs a mental health charity for parents, Leo's Neonatal, so she should know. And just some final closing words from Emma, who unfortunately can't join today, but Emma's one of the co-authors on our paper, and she's the mother of 23-week twins. So Emma said this about the cuddle she had and with her little baby Jack. She says, a cuddle is so important. Being able to hold Jack right after birth meant the world to me and was so special. It's the hardest thing in the world, not having your baby near you after delivery, and you hold on to that one cuddle you've had. The cuddle I had with Jack when he was born meant so much, and all mums should have this opportunity. You can read a more detailed account from Emma, really touching account about what the cuddle meant to her. It's one of the supplementary files which is freely available, attached to our Acta Paediatrica article. And I should also say, with very kind permission of Sheila and Hubert, that the little video clip is also attached as a supplementary file of Sheila's little delivery room cuddle with Nicodeme. So I believe it is important, really important. I believe it's irreplaceable. And this is happy first family together with Emma, her partner at the time, and one of their twins. And really sad, as you read about it in Emma's story, little Jack didn't make it, and he actually died 11 days later from sepsis. But it's the importance of what the cuddle meant for Emma is she's been a real protagonist, along with Sheila, helping explain from the parents' perspective the importance of it. So I do encourage you to read her full story. I'd like to end this talk by special thanks reiterated to Emma, to Sheila, and to Paul Corley for the really enthusiastic support, development, and promotion of the concept, and also helping together we've written that article. And I'd also like to thank Dr. Sarah Bates for her support, and also Lottie King for allowing us to use her quotation as well in the article. Last but not least, I'd like to thank all my colleagues, nursing, medical, midwifery, obstetric in Norwich for support over many years for this practice, and they remain very enthusiastic as a unit for offering this. And that's our paper there. So as I say, it's freely downloadable. It's basically this talk in a bit more detail, a bit less detail in places, but I'd be honoured if you look at it and hopefully use it. Certainly the practical guides and figures will be really helpful, I think, for units that want to roll it out. So thank you all for your kind attention, and I'd be very happy, along with Dr. Paul Corley, who's also here, and Sheila as well. We'll try and answer any questions you've got between us. So thank you all for your...
Thank you so much. There were lots of comments and questions. Sheila or Dr. Colley, do you have any other words you'd like to add before we open it up for a few questions?
I was going to reiterate what Paul Clarke said about, I think really the Delivery Room Cuddle actually improving the care of these extreme preterm babies. So they have ongoing intensive care throughout the cuddle. Nothing is sacrificed. And the pure means that this baby has so much focused attention in the delivery room in terms of its observations and support means that actually, certainly if we just looked at the data from more contemporary cases, we're not seeing that hypothermia that historical cases have seen in NICUs up and down, certainly in the UK. So I think, as Paul Clarke said, I think you can improve your care through doing this. You're not risking anything. And the other thing that we make clear in the paper is that cuddling extremely preterm babies isn't a new clinical intervention. The value of the kangaroo cuddles for extreme preterm babies is well established. So I think we should take confidence from that as well.
Amazing. Sheila, did you have anything else you'd like to add? We're so grateful for you being here and for sharing the video.
No, I just think it's a fantastic initiative and incredibly important. And I'm grateful for people like you who help to spread the word.
Our pleasure. So there were a few questions. Lothy, if you're still on, if you want to unmute, and I see Dr. Tiji, I can unmute for you as well.
Yeah, wonderful presentation. We did a paper at Mercy in Chicago that during C-section, we had skin to skin for particularly term babies, but this is excellent. We'd like to start this. But the question is, in your data collection, did you see any complication impact? For example, was there less complications because you had cuddling or even skin to skin, or length of stay? That would be very important in supporting your idea.
Thank you very much indeed for sharing details of your work as well. So to answer your question, it's quite limited what we've done because it was inevitably retrospective. We were limited in the quality, the amount of data we could collect. I've already mentioned we weren't able to consistently gather sufficient data on pH, for example, or duration of cuddle or admission glucose, because it was often very poorly recorded in historical cases and wasn't always present as it should have been in case notes. So I think we're going to get far more robust data prospectively going forward. There's many units now, certainly several in the UK, that are routinely practicing it. And I think over the next year or two, we will start to see prospective data which will reassure more and more people about the safety of it. But certainly in our own experience, anecdotally and from our limited retrospective review, we're seeing no safety issues of concern. And as I said, it's been practiced for 20 years on and off in my unit. It's become routine practice now in recent years. We've seen no safety issues whatsoever. We've not seen any babies that have dislodged tube during cuddle, thankfully. I'm sure it'll happen one day because it happens all over the place. But no, we want to make it sure. And we guarantee it as safe as we can be because the most senior person is there supervising it second to second throughout.
Hi, Kathy, can you hear me?
Yep.
Hi, thanks for the great presentation. I really enjoyed listening to your project. I have a couple of questions. One is, so do you guys talk to the parents, mom or dad, before delivery during prenatal consultation about the cuddling, just to prep them? And any discussion about that? And how do you prepare the staff? Did you guys have any guidelines or education for the staff on how to start this project? That would be great.
Thanks very much, Melanie. I think the ideal is, I think I mentioned it in the talk, that we try and discuss with parents antenatally when there's usually more time. And that would be the ideal. It's not always possible if the mum comes in and needs delivery or suddenly delivers. But that would be the ideal, and it would be part of our routine antenatal counselling these days to tell them about what to expect following delivery, what we'll be doing initially. Don't get worried if we're all busy with baby on the table for the first 5, 10, 15 minutes, but then we'll do our utmost, if everything's stable, to bring the baby over to you. So we're already introducing it as a part of our routine practice. Nowadays, I think if units are starting to adopt it and roll it out, it probably would happen in a more formalized way than how it's increased over the years in my own unit, for example, where initially there was just 1 or 2 of us maybe been practicing it as senior doctors, and the nurses seeing it, getting really enthralled with it. And I think if I may mention, 1 or 2 of the, you might say, slightly negative comments that came back from parents, really important to present them because we learn from them. And the comments about thinking we were delaying the baby's intensive care, that mum was feeling guilty that she'd taken something or denied something to that baby by accepting the cuddle. And to me, that just told me, actually, that mum's not being prepared properly, either before birth or following birth. And I can imagine what's happened there. Probably very enthusiastic nurses who've seen it done and have encouraged junior doctors who may have come into our unit from elsewhere, never having seen it before. They've said, oh, let's do that now. And actually the mum's probably been forgotten within that process that they really need very detailed counselling on what to expect. And that is our normal practice. Don't be worried, we're not delaying intensive care, we're providing it second to second. Your baby's going to be completely safe throughout the process.
Excellent. Do you want to speak to this trend around, or this focus on the golden hour, and just maybe reiterate, where does the cuddles fit into that golden hour? And maybe we should call this this is like the diamond minutes inside a golden hour, where I think what you said is only just a few minutes. And even in Sheila's case, where it was a more prolonged experience, was still only 9 minutes and in that whole time. And where do you think that this fits in that golden hour idea?
If you don't mind, I'll defer to one of our national experts here to answer this one. Paul's done a lot of work around first hour care, so go for it, Paul.
Yeah, I guess the key thing is to think about what you want to achieve in your golden hour and what is your real priority. And also in the back of our mind, we should consider how valuable achieving everything literally within 60 minutes is valuable. It's not got the same evidence behind it that, for instance, major hemorrhage has or antibiotics has in sepsis in adults. I'm very interested in first hour care, and I think it should be seen as a strategy for achieving the things we need to achieve efficiently and working well as a team. If you can achieve all those things at 65 minutes and have a 5-minute cuddle and involve the family within that hour, that's far more valuable than purely ignoring the role of the parents in this baby's care. But as we've seen from the data in Norwich, actually, the group who received the cuddles were admitted to the NICU sooner than those that weren't. I think if you're being efficient and working well as a team, you can still achieve everything you need to in that first golden hour. But my priorities would be the family, respiratory stability, access, glucose substrate, and antibiotics if there's an indication for sepsis, and definitely you can achieve that.
Awesome. I love that you said if it's 65 minutes, but we can give 5 minutes of cuddle. I think it's always the golden rule about the golden hour. What would you want? And we should try to prepare those things the best we can and provide those things. One of the other things I was going to ask, if in looking back in retrospect, if you were rolling this out, would you start with, I think someone mentioned they're already doing a lot of this with term babies or well babies, and would you roll it back slowly using maybe the higher limit of your preterms and then working to the 22 weekers, as opposed to starting with the 22 weekers tomorrow while everyone is still embracing the idea?
I think that's a perfectly reasonable way to go about it.
Just give that security to everyone.
Kathy, do you mind if I come back to can I come back to the previous question? Because I meant to ask Sheila, we got a question about the counselling, and I honestly can't remember whether we'd spoken to Sheila before the birth or after the birth. Can you remind us, Sheila, when it was?
I think a few days, so maybe Sunday, Monday, I think it was the day or two before the birth. Priya, the neonatologist, came in to speak to me first, and then Dr. Sam. And then I was able to speak to them. Whenever I had questions, I could always call in. They were very happy to speak to me. So I never felt that I was left to just wallow in my own thoughts about the process. I always felt very looked after. I have a very good recollection of that moment, and they were always on hand to answer any questions, and there were many questions.
Thank you, Sheila.
Awesome. So someone who just made the comment, this isn't really skin to skin. The idea is this opportunity to hold and to have some time of closeness. It's not the same objective of all of what we think of in offering skin to skin with the thermal stability and for prolonged periods. It really is taking advantage of those just brief moments between that transition from our stabilization time to the NICU. And instead of, like you said, the flyby, hi, here's the baby, it's just pausing and providing that. So can you speak to that, maybe just the rationale behind that?
Yeah, I mean, it's always been the natural thing to do. They're not our babies, they're the parents' babies. And it's just the realization, which is not rocket science, that once we've taken the baby away, these tiny babies, it's days and weeks before they can get the first cuddle. I'm aware in some units, for example, in Austria, in Vienna, I know that they practice early contact in a different way. They've got the ability there, which is not something we've got in the NHS, to be able to wheel the mum's bed right alongside her and then get the baby out from the incubator onto her within a few hours of birth. So it's still not quite the same thing, but it'll be fascinating to hear from them actually in one of the future sessions how they do it. But yeah, we're talking about that moment, and it is a brief window where the baby's as stable as we want them to be. We're happy they're stable, and when we'd normally be shifting them to the unit to attach them to all the monitors and leads and put cannulas in and UACs in it. And you're all well aware how quickly these babies can become unstable, even within a few hours of birth. We're at that moment in the delivery room. It's a beautiful period of stability for the vast majority of babies. Once we've sorted out the airway, the heart's fine, the saturations are good, the temperature's good. They're as stable as we can hope for over the next few days. So it's a really good time to utilise. And it's such a precious time for families. Fundamentally, it's what the families need to bond, that initial bond, to give them the hope, to see the baby stable, actually see and feel that the baby's stable. And there's really nice discussions going between doctors and nurses. I hope you got a flavour of it from the way our nurses, lovely little comments back and forth, reassuring the parents. And it was such a really pleasant experience. It was such a nice delivery to have been at that one. It's a real blessing. But yeah, if we don't utilise it, then the babies get trapped. And just go into your own units and ask your mothers of 23, 24 weeks on your units, when did you first get a cuddle? And they'll remember, if not the hour, the exact day postnatal. And for many, it'll be 2, 3, some 4 weeks down the line. I think I showed you Emma with her little baby Jack that unfortunately died. His twin, it was about day 63, 7 weeks before she first got to hold him. So it's simply enough to give a cuddle for the baby in the delivery room. I think she'll say the same. I remember asking you, Sheila, it was something like 5 or 6 weeks, was it, before Nicodeme was able to have that second cuddle? Is that right?
Exactly, yeah. It's about, 5 weeks.
Yeah, I wonder, Kathy, I'll just make a point about the skin to skin as well. So in the video and in the photos, we can see the baby's in the plastic bag and swaddled in the towel. Another way, if mum's temperature is okay, another way of doing it is having the baby in the plastic bag on mum's chest and then overlying preheated towels. And you are increasing the contact in a way doing that. But I would say I would always be keen to have the baby in a plastic bag. We know that we can achieve humidities of around 67, 70% in the plastic bag, and without that you would increase your fluid losses from the baby so early on. So I think a plastic bag and then overlying towels is an alternative, but I would always have them in a plastic bag and making sure the room temperature is warm as well, 26 degrees.
So I'm surprised no one asked about any kind of precautions for IVH. Do you take any precautions as far as the angle of where mom's sitting, how the baby is lying, supporting midline head positioning? This is always a hot topic, and I wonder how you guys have resolved this for those moments. The baby looks really nicely snuggled and contained. Do you have any other tips around that or suggestions of what you have done?
It's an interesting question and interesting thought. I must admit, we've not really thought about those issues. We're trying to maintain the babies in a similar position as it would be on the resuscitator, but albeit cuddled, is very secure, as you've seen there. It's an interesting question. It'd be interesting to hear whoever's asked the question if they've got any comments on that or good practices that we do need to be thinking about.
I have another question, if I may.
Yeah, go ahead, Dr. Teji.
How's the temperature of the delivery room? You keep it warmer for preterm babies as a routine?
It's a good question. And we've learned lessons the hard way as a region and as a unit. And we now increase the temperature of the delivery room. So the normal is about 26 degrees, is it, Paul? We aim for. We often need to keep reminding people to do that. But it's been one of the important factors in reducing hypothermia. But I think Paul's done a lot of work. Hopefully he'll publish it one day on the continuous temperature monitoring. That's also made a big difference as well. If we can see what the baby's temperature is minute to minute, then we can act on it quickly before it carries on going down and down. And that's been a great thing for early intervention as well.
Additionally, preterm babies usually need just bagging or just oxygen. It's not like term babies where they will call a neonatologist for a low UPGAR state or fetal distress. Preterm babies are premature because some other reason, not usually due to hypoxic event. So maybe it'll be easier to keep a preterm baby in good state. But I've noted contact of skin does make quite a difference to the baby's state compared to gloves or just plastic bag. In my own personal experience, baby put his leg over my ungloved part of the arm and he was silent. And I said, wow, this has taught me something, that skin contact is something so superb that we realize when we do it. And it was me, but the baby touching the mom would be the imperative response to the mother and the baby. I think I'm at a loss of word when mom says, so I won't take a look at the baby, even his 35-weeker in 24 hours. And I just feel this was such a timely presentation. Thank you very much. You have a lot of ideas. Appreciate very much. Can we have a slideshow copy so I can share?
I think that the article does a really nice job of probably outlining all the literature you mentioned. But Dr. Clarke, if you want to provide your email, if anyone wants to reach out to you and whichever parts of the reference list you want to share, that would be great. I think people are very keen to keep learning more and to expand this to their practice. I did want to comment that I thought with Sheila and in her delivery, they were touching the hands, and that is still also some skin contact too. So Dr. Teji, maybe that's one way to maintain that plastic wrapping, to maintain that humidity. The thing is that none of us would think anything about having the baby in the plastic wrap, in blankets, in the bed, and why we think that there's like a problem with the baby being in a plastic bag, in a blanket on the mom. I think we just have to check that inconsistency in thinking and saying, where is really the natural place this baby should be? And the place is with the mom. And again, as you both have eloquently said, things can change in a moment. And we've shared stories where these were some of the first holds and only holds that were maybe not part of the goodbye time. And so these moments, I think it's just one of these things we have to take back and say, you know, you can't do everything, but can you do something? And if in your unit, you're not doing anything like this, just starting the conversation, sharing that you were here, sharing the article with your colleagues, starting to talk about what could be our first steps to beginning to offer this, even if it's your own mindset, you know, you attend a 35-weeker, 36-weeker, just a little low sugars, how much more can we offer even in those more stable moments first, and then move this as a trend towards other sicker babies. So I would challenge all of you to think, what can I take from today and what can I do in my unit to do something different, to begin this conversation, to allow for the families to have the right to have access in a more powerful way. And I thank both the Pauls and Sheila and Emma and all of the families who contributed to this survey for just leading the way and always showing an example of what's possible. And then we can't say it's impossible. It's possible. We've seen you guys do it. You have the video and we hear the testimonials. And so we no longer can live in a place where it's not possible. We now see it is possible. So thank you to both of you for being here, late night, evening for you and for your staff who've joined. And Sheila, thank you to you for being with us, and just thanks for the work and for being here with us.
Thank you.
Any other final thoughts or questions? I'm looking to make sure that haven't missed anything. But thank you all so much. I think we'll wrap up there. Thank you all for being here. Thank you, Judy, for the little heart. And thank you, Paul and Sheila, again, and all of you for joining us. I think we had some of our best attendance ever. I knew this was going to be a topic all of you wanted to hear. I think you should all bring your videos on and say goodbye and wave. Come on now.
Bye-bye.
Bye.
Thank
all.
you. Bye, everyone. Bye-bye.
Bye.
Bye, everybody.
Thank you, Paul. Thank you, Paul.
It's been a pleasure. Thank you, everyone.
Thank you.
Thank you.
Hey everybody, welcome back. It's Kathy Randall from Synapse Care Solutions, and we are ready to have another Monday live stream with you. Today's presentation addressed the issues of delivery room cuddles. This is a practice that has been going on in the UK for over 20 years, but it has recently had a lot of attention, some new publications, and we were so lucky to have Dr. Paul Clarke, Dr. Paul Cowley, as well as a family who has experienced delivery room cuddles talking to us about the impact that it had and just the benefits. This was one of the most popular presentations we had during the pandemic. It was on one of our Synapse community calls, and I'm so excited to be able to bring it back to you. If you'd like to have some of the resources that are mentioned, as well as the slides, go ahead and scan the QR code here, or check out the show notes below for more links on this and other Synapse Care programs. So without further ado, please enjoy this presentation. Thanks again, and I will see you at the end. Well, thanks for watching. I hope you enjoyed the presentation. I'm really glad to be able to bring back these past presentations from One conferences, from courses, and from our community calls so that you can remember all of these amazing individuals who are doing such great work around the world, but also so that you can continue to make changes in your nursery. Without the generosity of these individuals, we just couldn't continue to spread the word. So thank you again to the families and to Dr. Clarke and to Dr. Cowley who were with us and who were able to share so many important details. I hope you'll download their article, go ahead and look at the supplementary videos, and you can scan the QR code here so you can get a link to all of those. And again, just have a great week, and we will see you next Monday for another live stream. Bye.